record, I think. Bismillah ar-Rahman ar-Rahim. It's a great honor for me to welcome all of you in the new project joined between the Egyptian Orthopedic Association and the first time with Friendly Park Hospital. Many thanks to my dear friend and my dear brother, Dr. Muhammad Hashim from Friendly Park Hospital for innovating and starting this journal club. It will be in the middle Friday of each month for 1 year, inshallah. And we will start with this this event, this big event today. And Dr. Muhammad Hashim will be the moderator of this session. We have two speakers from Friendly Park Hospital. Plus, the first speaker will be Dr. Muhammad Hashim will speak about the idea of the journal club and how can we make maximum benefit from it. Please, sir.
Thanks, Professor Ashab, and good evening, everyone. My name is Muhammad Hashim. I'm a consultant for an ankle surgeon in Friendly Health NHS Trust in Northwest London. It's a pleasure, and it's a really pleasure to have you today. And in a regular journal club, we'll be running every month and the second Friday of the month. We have very good two eminent speakers today. James Richards will be speaking to us about the WAX trial, and Mohammed Hussein will be speaking about the TopCat trial. So it will be beneficial to all of you. You will be, by the end of the session, you will have a feedback, you will receive certificate to add to your portfolio. And I hope it will be beneficial to all of you. You will have a new up-to-date idea about what's going on, the new trials and all this stuff. I will start with a quick presentation about what is Journal Club for who doesn't know. And I hope this will give you an insight what's Journal Club, what we aim from this event, and you will feel that your time today is very useful. So to say what is Journal Club today, I'll be running very few slides. So what's Journal Club? It's basically a regular meetings which we organize. All of us will meet and start to critically evaluate a paper or a novel study which is recently published and try to get from diverse perspectives what's going on, trying to get different members of the journal club to give their input. And so we all share in appraising the paper and know what's going on and get the maximum of it. The aim from these journal clubs is to enhance the knowledge, especially the up-to-date knowledge. So as you know, all of you know that information never stops, and the knowledge is every day evolving and upgrading. And to know up-to-date knowledge is the keystone of knowledge today. So basic knowledge or classic teaching is not enough. You need to be up-to-date with all the new evidence and the new knowledge evolving every day. And the journal club is the way to do that. So we meet together, have a novel paper, 1 or 2 papers, starting to appraise these papers, know what's good, what's bad, try to get the good things, try to avoid the bad things, and then have a diverse discussion between all the members of the journal club to come with a novel idea about what's going on and what is the update. The purpose of the journal club is to review the current research. So we discuss, analyze all the latest findings and trends in the field, try to keep all the members up to date with the current state of the research. We try to promote the critical thinking. So there is no frank knowledge. All knowledge has to be critically criticized. With the critical thinking is a very, very good practice to understand how to get the benefit and the maximum of every knowledge you read. Try to facilitate the exchange of idea. If we have a diverse members in the journal club, we'll be hearing different sounds, we'll be hearing different experiences, we'll be hearing different backgrounds, and this will add for all of us. So every one of us gets from the other, because definitely every one of us has something different than the other. If we look in the benefits of participating in a journal club for the participants, it's firstly will keep you up to date with the latest research in the field. It develops your critical appraisal skills as attendants. It's not only the presenter who will be critically appraising the paper, but it is both the presenter will be presenting you his critical appraisal, and you have the chance in the active discussion to critically appraise the paper from your end. And definitely, every one of us have something which the other doesn't have. So we'll get from each other. It improves the presentation and communication skills mainly for the presenter, and it definitely builds supportive network of peers when we meet together from different perspectives. The format of journal club, either we choose a single research article, so we discuss only one article in depth and critically appraise it. Sometimes we choose a topic, and from this topic we look at multiple articles, multiple up-to-date articles to appraise. And sometimes we specify certain study designs or methodology and focus on that. And sometimes we're just reviewing the literature or the meta-analysis. And what we are doing today, we are looking into a specific type of papers, which is the trials. So the randomized control trials is one of the strongest evidence at the moment, as you all know. And we focusing today into two big trials, which has been done with a very good and robust evidence, which you can use in your practice and definitely will change your practice. The key elements of the journal club is firstly to select a high quality article. We're not discussing every article, we're discussing the novel papers. Then the novel papers or the high quality articles is the one which needs to be discussed, the one you need to know about. And we prepare a critical appraisal of the article. So this is when we choose our very eminent speaker. So James Richards is an ST4 trainee in Thames Valley, Dennery, and he has a very good experience with research and critical appraisal. And so choosing him to appraise the paper is one of the elements which make the journal club really beneficial, and you will get something different than if you read the paper yourself. So we prepare a critical appraisal of the article to show you the other side of it. It facilitates engaging in a discussion among the members. So the critical appraisal James or Mo will be giving us today is just an opening statement. Then we'll take from this opening statement an active discussion to know what's inside the paper. Everyone put his input, and we come with a collective idea. What is the evidence? What's good in it? What's bad in it? And what shall we change in our practice? And definitely, it encourages active participation and feedback. The rules in the journal club: the moderator, which is Professor Ashab today, who has a very, very huge experience in the medical field, especially the online medical education. The presenters, we are thankful for their time they use to appraise the papers and present it to us. And definitely all of you, which are the main aim of today, as a participant, to actively discuss and share in this, give your insights, ask your question, contribute actively. So you appraise the paper from your end. So you check with the presenter his critical appraisal, because the aim for all of us is to come with a clear idea what's up to date evidence. For an effective journal club to happen, we have to have a certain clear goal and expectation from the group. We have to establish this as a regular meeting, because the knowledge will keep evolving. The knowledge will stop evolving today. So that's why we're making the journal club a monthly one under the Egyptian Orthopedic Association. And we have to encourage diverse perspectives and include all the people. That's why I opened the registration for all of you. It's not only Egyptian, it's not only from Middle East, it's not only from UK, but we encourage diverse perspectives and inclusion from everywhere. We need to hear all the ideas, we need to hear all the voices. We need all of you to exchange experiences and exchange insights, so we get the maximum from it. And definitely at the end, we need to have a constructive feedback to the presenters, so they know what they did well, what they did wrong, what they need to change next time, so they will get the benefit from it as well. So if you are the presenter for the next journal club, you need to understand how to appraise a paper for a journal club, which is very, very important point. So to appraise a paper from journal club, there is certain points on the paper you need to look into. So basically, the introduction, the methods, the results, and discussion, weaknesses and strengths of the paper, and how to reproduce this paper locally, which is the main aim. So in the introduction, you need to see the background of this paper. So have they explained in their introduction the background they are coming from, why they think about this paper. You need to appraise, have they choose a proper topic. So is like the topics we're discussing today, one is the weight bearing status after ankle fixation, fracture fixation, and the other one is a comparison between unicompartmental and total knee replacement. So both of them are clinically relevant topics. Both of them are very good topics, which is a daily practice. We cannot get a topic which is done like very, very rarely, and or topic which hasn't no debate. You have to appraise if they have chosen a proper topic to discuss or not. You need to be careful. Do they have any bias in this paper, and have they justified these biases or not, and if this bias is inappropriate or not. The most important in your introduction to look of the paper to look in is the BICO question. And the BICO question, BICO stands for B is for people or population, or a problem. I is for intervention, and C is for criteria of conclusion, inclusion or exclusion, and for comparison or control, and O for outcome. To have a proper research question, your research question has to follow this format. You have to have a clear population you're looking into, a clear problem to look to search about, a clear intervention, a clear inclusion exclusion criteria, and if you're doing a comparative study, a clear control group, and at the end, a clear outcomes, primary and secondary. Then have the suggested null hypothesis, which they try to debate or try to deviate or not. And the purpose of the paper, are they clear in the purpose why they did this paper, and if the question they make is important and necessary or not. And lastly, have they done a literature review to be sure that hasn't been searched before or not? Because without a literature review, we keep repeating the research, which is not proper and in a waste of resource and time. So literature review is very, very important to tell us that this research is a new research, is something which will add. So for the methods, you need to look into the study design. And we have a lot of study design, just descriptive designs like a review article, case report, case series, and experimental design like a control trial, the most randomized control trial, case control trial, cohort studies, and definitely systematic reviews and meta-analysis. Then you need to be sure that the study design the author choose is appropriate for the research question they are running, and they must have a clear inclusion exclusion criteria to avoid any selection bias. They must have a control group if they are doing a comparative study, and you need to see if they have proper technique and have they document this technique properly or not. Have they choose a proper sample size? Have they done a power analysis to know what sample size which will give them a statistically significant results or not? And regarding the statistics, you need to see if they have used an appropriate test for the nature of the data, if their data is parametric or non-parametric, and have they used like a proper experimental design, a statistical test appropriate for their experimental design. Then you need to understand, have they described sufficiently the data? Have they analyzed it properly and interpreted it properly? Then when you come to the results, you need to find what did they find, and has they represent these results correctly and completely, and is this consistent with what they say, and how the results and analysis are important, and if the results are clear and objectively presented, both in a text and in figures. Is these figures informative and necessary? If there is any unnecessary redundancy in the text or figures, and if the results are valid and significant, and definitely have they answered the question they started with or not. In the discussion part of the paper, you need to see if they have an interpretation which is consistent with the result they presented. Is the discussion appropriate for the scope of the results, and does it overreach? Do they fit this finding into a bigger picture? So how the research question be answered fits in a bigger picture of all the evidence available? Do they answer the question they ask in the introduction or not? So is the discussion ending by a clear answer for the research question, or just waste of time? And is the discussion organized, logic, understandable, necessary, or relevant? Then you need to answer, have they addressed the alternative explanation and discrepancies or inconsistencies? And have they addressed any disagreement, opposing evidence, or different theories or opinions in the literature? Then you have to find the area of strengths in this paper, and also the areas of weaknesses. Every paper will have some strengths and have some weaknesses. There is no paper with absolute strengths or absolute weak. It's different. Definitely have some strengths and some weaknesses, and where these weaknesses were correctable and why they didn't correct it, and if there is, because sometime if they don't if the weaknesses are correctable and they didn't correct the weaknesses, this is mostly an intended bias. And does these weaknesses affect the quality of the evidence or not? Then in overall, you need to come to me with a result. Is this paper is important? How will it impact on the field of the orthopedics? And how will it impact on my practice? And will you cite this paper or not? And could you base a future research on these findings coming in this paper? And the most important, will you reproduce the results locally or not? Because the main point we are here for today is to get up-to-date evidence to use it in our practice. If the results they are coming with is not reproducible in our local practice, doesn't make any sense. So if they're speaking about like robotic, and I don't have a robotic, this research, even is a very good research, it's not relevant to my practice. So we need to be sure that the results we have seen in this paper is reproducible locally. That's why when I did choose these papers, I chose 2 papers which related to the practice in Egypt, and I'm very sure that practice in Egypt and Middle East has a fracture, ankle fracture fixation, and definitely there is a debate about early and late weight bearing, and the practice there have a total knee replacement and a uni knee replacement, and definitely there is will I use a uni knee or a total knee, and when I use that and when not to use that. Thank you so much.
Thank you so much, Dr. Muhammad, for this very interesting talk. I will let you introduce our speakers today, please.
Yeah, so James Richards, as I elaborated before, is an ST4 trainee in North Thames Valley. James.
Hi, Mo. Thanks very much for the introduction. It's a pleasure to be here, and thanks very much for inviting me along to present at your journal club.
Sure.
And I will try and hit all the standards that you've just kindly set out in your first presentation. Right. Can you hear me?
Yeah, we do.
Yeah.
Excellent. Right. Let me just share the screen and we'll get on to it. So as Mo is saying, so I'm presenting the WAX trial is the acronym, but speaking, what they're comparing is early versus delayed weight bearing following post-op ankle fractures, and it's a non-inferiority multi-center randomized control trial. There's all the authors there. It was done in the UK, and yeah, my name's James Richards. I'm a orthopedics trainee. I'm at Wexham with Dr. Hasham at the moment, and I'm a Oxford Deanery trainee. So what are they looking at? Why are they doing it? So ankle fractures are common. I'm sure they're as common in Egypt as they are over here. The data that we've got shows that we have about 190 a day. Now, obviously, not all of those are operated on, but it does show that they're at least a very common injury. And at present point in time, there's a lot of variation in what people do post-operatively because the evidence, one way or another, is fairly limited, which is what this trial is aiming to address. The most common finding that they found from the literature was that 6 weeks non-weight bearing for any patient, that could be in a cast, in a boot or otherwise, but the 6-week bit with non-weight bearing was the most common finding they found. They actually surveyed some patients who'd had ankle fractures fixed and looked at all the data, and they found that they tended to return to work with delayed weight bearing, and also just by basis of patient preference, if they knew it was safe to do so, they would much prefer to be walking on the ankle earlier if they could do so. So that's the kind of benefit that they were entailing with trying to show that early weight bearing is or isn't reasonable. In terms of how they designed the trial, it's what we call a pragmatic study. Sorry if I'm teaching you all the obvious here, but these are quite common at the moment in orthopedics. They basically are trials that are kind of done within centers that do the work day to day. So it's not done in a lab and it's not done in a kind of overly carefully created research environment, with the aim being that it is with your day-to-day practice and it's assessing it in that environment and accounts for all of those variabilities. It's what we call a non-inferiority trial. So it can show that one is just not worse than the other because the benefit is already noted at the start. So they're saying that patients prefer it and there's a return to work early. So if there is no harm from weight-bearing patients early, then we should do so. It's a multi-center randomized control trial, which is a very high level of research. It's just below either meta-analyses, essentially. They did a literature review, which is in the actual full paper, and essentially there was no high-level evidence, certainly not to this level, outlining what to do. I think there were some single-center RCTs, but nothing to this degree. And as I've said, they're comparing early weight bearing, which was classified as being at 2 weeks, versus delayed weight bearing, which was at 6 weeks. I know we're all surgeons here, so we get impatient. So the headline result basically was that they found that it was not inferior to delayed weight bearing. Now, there are some provisos on that we'll come to shortly, but they actually, in their evidence, switched pretty early on to not trying to show that it was non-inferior, but actually trying to show that early weight bearing is superior to delayed weight bearing. Who did they include? So include anyone over the age of 18 and who had fixation within 14 days of the injury, which is a really nice broad group to capture, and is very applicable to day to day. They didn't just say, young males who had a certain type of injury. This was anyone over 18, as long as it was fixed within a reasonable time frame. They did exclude a few groups, so hindfoot nails, peripheral neuropathy, so avoided those people who might develop Charcot-type joints. Anyone who had lack of capacity, and surgeon's decision is a key one, which we will come on to talk about in a bit more detail shortly. What were they actually measuring? So their primary outcome was the Oliver ankle score, which is a well-validated patient-reported outcome measure that's out of 100, and their MKID, or minimally clinically important difference, was a score of 10 difference. Other things they look at, which is obviously things that surgeons have concerns about, so that's failure of fixation, DVT, wound problems, CRPS, and there were some others alongside that. Their follow-up was pretty good, and what is fairly standard for this type of trials, they follow them up at 6 weeks, 4 months, and then at 1 year. Patient selection. So I kind of erred and highlighted a little bit of this earlier. So the bits in circle are the key bits to pick up here. So they kind of initially flagged about 2,200 patients, but exclusion group, there was 940 almost who were issued non-weight bearing instructions by the surgeon. So they were ruled out of the trial, and they don't really necessarily explain the exact reasoning for this because I don't think they collected that data. And then as they got further on, there were a further 70 that were removed from the trial for lack of surgeon equipoise. And we'll come on to assess what that means for the utility of this trial a bit later on. They did do a decent power assessment. They found that they needed a minimum of 436 patients per group, and 436 patients with 218 per group, which they did achieve as part of their trial. As it was randomized, they obviously stated what their group characteristics were, and they were comparable for all of these subsets: so age, BMI, sex, mechanism of injury, which malleolus was involved, whether or not they had syndesmotic fixation or not, whether they used cast or boot, diabetes, smoking, osteoporosis, alcohol use, and employment status. So it's good that all of those factors were controlled for across both groups. So those cannot be used as confounding factors. Coming on to some of their data. So the OMAS data, broadly speaking, showed there was a slight benefit that was statistically but not clinically significantly different. So in all ways that they analyzed it. So by the protocol, there was a kind of 4 to 5 improvement. They did what's called a CACO analysis, so complier average causal effects. And basically what that does is it removes those from each group that were non-compliant with whatever the prescribed treatment plan was. And in that group, there was an even higher difference. Though, as I say, none of these groups were clinically significant. They were only statistically significant. And the difference was much more so earlier on than later on, as the graph on the right shows. So that is pre-op, 6 week post-op, 4 months, and then a year post-op. And you can see that the gap does narrow somewhat, but doesn't fully close. They looked at the EQ5, which is a more broad assessment of quality of life that's very common in these papers. And again, there was initially a significant difference in favor of early weight bearing, but then again, that also tapered off towards 1 year. In terms of what they saw from complications, now the big problem with this is the actual number of each individual complication is obviously very small. It means that getting a statistical difference is very difficult. With the arrows on the side, I've highlighted some obvious points of interest. So failed fixation, which is the big one we worry about with early weight bearing patients, or loss of reduction, either or. There was an increase in the numerical value for the early weight bearing group of 4 relative to 1 in the delayed weight bearing group. But as I say, that's not a statistically significant number. So whilst there is an indication there, it's difficult to draw a true conclusion. CRPS was the reverse, essentially. So there was 4 in the delayed weight bearing group and none in the early weight bearing group. And a point of interest for me was that DVTs were actually not different across the 2 groups, which was something else that we may expect from weight-bearing patients more quickly. Financial impacts. This is obviously in health service in the UK, so it may be different if done abroad. If you only take the NHS context, early weight bearing is a little bit cheaper, but not a significant amount in the grand scheme of things. The reasons for that were there were slightly fewer physio appointments required, I think, for the early weight bearing group versus the delayed weight bearing group. From a broader economic perspective, so that includes people getting back to work and all things that go alongside that, the early weight bearing group was a much better impact from a wider societal perspective. Coming on to the pros and cons, strengths and weaknesses of the trial. So as I said earlier on, they had a very good broad inclusion that's very applicable to a lot of patients that we see on a day-to-day basis, and their exclusion criteria were useful because we often do different things for people with peripheral neuropathy anyway. And they had a reasonable follow-up period to about a year. You can always criticize these trials for saying, oh, you don't follow them up until, you know, patients can get arthritis, but it's actually very difficult to do that because you'd end up following up patients for 5 or 10 years even to see what their outcomes are. And that's not easy to do. Weaknesses, as I said, it's not actually a weakness of what they've done and how they've analyzed things, but in terms of the utility of the trial to day-to-day practice, they have a very high dropout rate from surgeons' preference. And this is a common issue with any pragmatic trial because the surgeon can decide just not to involve the patient for whatever reason. They don't necessarily have to state that. They did look into this a little bit and had spoken to a number of different surgeons as part of the trials, and the kind of broad consensus was that there were concerns over fixation stability. So it may be that when they were doing the operation, they weren't absolutely sure that they got things like anatomical reduction. Their screw bites may not have been as good as they thought they would be, or otherwise. But as I say, it's difficult to draw any decent conclusions on that, and that does limit somewhat the utility of the trial overall. Some points of interest, some of which I've touched on already. The first one there is actually is quite an interesting one. So of the delayed weight bearing group, almost a third of them didn't adhere to instructions. So a lot of them would just weight bear despite being told not to at 3 weeks. And I think that's a really interesting point to draw, that no matter what we tell patients, they may just sometimes do what they want to do. And they haven't pulled these out as a subgroup to say, well, is there any issues with those in terms of loss of fixation or otherwise? But I think that is an interesting draw from this study. Another point is that the OMAS scores for both groups were still about 20 points below what their baseline was pre-operatively and pre their ankle fracture. So when we're seeing patients who've got an ankle fracture before we operate on them, I think we need to be very clear with them that the recovery from this is very long. And even after a year, they may not be back to what their baseline was and what they're expecting is. So there is a bit of expectation management to do with patients, however you manage them, essentially. As I said, there was no difference in DVT rates. And the overall summary is, in most cases, on average, it's reasonable to weight bear patients from 2 weeks. But as I say, that you can't fully commit to that on the basis of the trial because of those patients that were removed for surgeon's preference. Thanks very much for listening. I hope that was a useful insight to what the WAX trial is. And I'm obviously happy to take any questions now.
Thanks, James. Thank you so much. It's a really good presentation, as we always waiting for from you. For the audience who are new to the journal clubs, this one of the novel papers, because firstly, it creates a very, very important and a clinically relevant topic, is ankle fracture fixation and when you weight bear your patient. The second point is the weight bearing is not only a functional treatment, it's not only the patient starts to regain his proprioception, is added to this a financial value because the patient is back to work early, the patient is back to rehab early, is back to his normal function early. The paper has been published in the Lancet, so it's a very good journal. It's a very, very robust evidence because the study design is very, very good. It's a pragmatic study. So and even the 2 points which is like of concern in the study, which is the dropout because of the surgical preference, the large number, the 900 something, which has dropped out, and the point that some of the patient hasn't already followed the advice, and the non-weight bearing group start to weight bear early. This both support that the trial is really pragmatic. So this is what actually happened. There is a good sample size. Our analysis has showed that the sample size is enough to reveal significant results. The results are statistically significant and definitely clinically significant. The other point, they widen the inclusion criteria, so they involve with some diabetic patient, they involve with some open patient. So it's very, very pragmatic. This is the actual day-to-day activity or day-to-day practice. So still, the only point about this study is you need to tailor it to your practice. It's your decision either to wait your patient early or late. A lot of surgeons will be changing their practice based on this study. And at least here in the UK, a lot of surgeons, especially foot and ankle surgeons, start to change their practice 2 weeks in a plaster till the wounds heal, put the patient in a boot, start weight bearing as the patient tolerated. So it's a novel paper changing the practice, and I think it's a very good paper if you want to go and have another look on it. And I think James has go inside it in a very good details, very nice critically appraisal. Thank you so much, James. And thank you for joining us, and thanks for your time.
Not at all. Thank you very much for having me.
Excellent. Mohsen, you ready?
Hello. Yes, I am.
Good. You share your screen, but just share the whole screen. Don't share the a window.
Okay, let me try that.
Dr. Mohammed, please let me welcome Dr. Mohammed Hussein.
Thank you, Dr. Hamid Al-Ashraf. Thank you very much. I'm really sorry. I'm not sure why the camera is not working. I've tried it at different times, but there's a technical problem with it. I'll try to sort it out after this. But apologies for that. So should I share the entire screen?
Yes.
Okay.
So quick introduction about Mohsen until he gets his presentation shared.
Can you see that
now? Not yet. So Mo is a senior fellow at Frimley Park Hospital. He's a dear colleague and brother, and yeah, he shared with this critical appraiser before, and he will be a regular, like a regular journal club appraiser for us in the next year. So.
Okay, it says it's sharing now, so I hope you can see it.
Yeah, it may take some time to share.
So can you all see my screen?
Not yet. Just reshare, Mohammed. Stop sharing and share again.
Okay. Let me try again. So share entire screen. Pick this up and share. So it says that it started sharing now. Like just literally give me that it is starting sharing. So I'm not really sure what is the problem. Okay. And then it says there is a technical error.
Okay, so I'll send me the presentation. I will show you.
Okay, I'll send it to you. Okay, I've sent it now, Mohammed. Have you got it?
Just a minute. Sorry, guys. Technical issue. Just a minute.
Yeah, apologies. Really sorry.
No, I got it.
Let me see if I can try and share again here.
No, don't worry.
Maybe it will work.
Yeah.
Have you got it?
Yeah, yeah. You see my screen, yeah?
Yes, sir. We can see it.
Good.
Yeah, I can see it now.
Go for it.
All right. Yeah, apologies for that. Thank you, Mr. Hashim, for introducing me for this event, and always a pleasure to see Dr. Mohammed Al-Ashhar as well. Yes, I'm going to talk about the TopCat trial. It is a trial that was published in the Lancet in 2019, and as Mr. Mohammed Hashim said, this is a quite a big journal with a high impact and respectable, with all the big trials and papers that have been published in it. First things first, this is a trial that has been done to discuss the effectiveness, clinical and cost effectiveness between total knee replacement and what is known here as a partial knee replacement, or what's known as uni knee replacement in cases of medial compartment arthritis. As an introduction, this was a randomized controlled trial, similar to the WAX study that my colleague James has presented, and it has compared the results between the total knee and the uni knee in the medial osteoarthritis. It looked at clinical results and cost effectiveness at a 5 years point. As we all know, as a simple introduction, just to remind everyone, for medial knee osteoarthritis, we've got two main options. Either a uni knee replacement or a total knee replacement, and there's often a lot of controversy between surgeons, which one is better, which one should I do. I've always done a total knee, always patients have been happy, and some surgeons say, well, I prefer to do a uni knee, less surgical time, a better outcome for the patient, less surgical stay, and minimal pain and early recovery. And there's always this debate, which I find is quite interesting and useful, and it's all in the interest of the patient. There have been a few studies, but none of them has looked at as this one, and none of them has been as big as that one. And they haven't addressed every single question that has been addressed in that study. So just to remind everyone again, a clinical picture. This is a uni knee. You only replace the medial femoral condyle, while the total knee you replace either both condyles, like tibio-femoral joint, or more recently, as everyone also replaces the patellofemoral joint, depending on the surgical expertise of the surgeon or his preference. So the objectives of that study was to assess the clinical effectiveness and cost effectiveness between both groups, and the secondary objectives were complications, which include operations, infections, revisions, patient satisfaction, happiness, and as well as cost implications for knee replacements. For our colleagues in Egypt, as we all know, the NHS offers knee replacement without any pay for by the patient themselves, but it obviously affects the cost of the trusts and the NHS itself, and that is a knee replacement that's done every single day in the country here. Obviously will have a big impact on the cost effectiveness, and the more you can save, the better for the NHS. It has been done across 27 major hospitals or sites across the country. The main criteria were patients who had only medial OA, medial osteoarthritis, and were candidates for the uni knee. After the patients were selected, they were assigned on a basis of 1-to-1 to receive a uni knee or a total knee, meaning that if you see, for example, 10 patients in the clinic who needed surgical, who needed a replacement, 5 of them would have been randomized to have a uni knee, and the other 5 would have been randomized to have a total knee. But that's also relied on the experience of the surgeon who was doing the clinic. After that, so this is so then after that, a baseline assessment was done for the patients, which include mainly the Oxford knee score, activity, the healthcare resources, and routine X-rays. The endpoint was a 5-year follow-up for these patients. Can you switch the slide, Mohammed, please? And then all the operative details were recorded, as well as post-operative X-rays were assessed, and the patients were assessed according to different knee scores. The main one that was used was the Oxford knee score, which is the most common and easiest used, but also the American Knee Society was used, and these were used as specific time points, mainly 2 months, 1 year, and 5 years. Next slide, please. So just to inform our colleagues in Egypt, Oxford knee score is a very common score that's used in our knee clinics in the country here. It's a questionnaire made of 12 questions given to the patients before they see the surgeon or after the surgeon in the clinic, and they simply ask them about their day-to-day activities and how their knee pain is affecting their day-to-day activities. Can they go up and down the stairs? Can they kneel down? Does their pain wake them up at night? Can they walk for long distances or not? Do they use any walking aids like a stick or a frame or anything else? And how significant is that pain? It's scored out of 60. And according to their score that they calculate at the end of the questionnaire, it kind of gives you a rough estimate about how severe their arthritis is. So the lower the score, the more significant their arthritis, and the more likely they will need a surgical intervention. And as the score goes up, it means that the knee arthritis is not that bad, and they can be managed with conservative measures if the knee arthritis is minimal and it's not affecting their day-to-day activities. Next slide, please. So it was done from January 2012 till September 2013. At the start, it included 962 patients, but after randomization and selection, about 45% were excluded. Either they didn't meet the inclusion criteria as according to their age, or they were lost to follow-up at some point, or they declined to participate. And then so 55% were remaining, which is actually 528. 94% of them carried on with their follow-up until the end of the study, which was at 5 years, and the rest were lost at some point due to declining to continue in the study or lost at follow-up. So the main result which is looking at is at 5 years follow-up. There was no significant difference in terms of knee pain and the outcome, clinical outcome. I have to stress this: the clinical outcome, not the cost effectiveness, which was the main other point that the study was looking at. As a study as big as that, statistics were made, and the confidence interval for that was 95%, which is a high statistical significance. Which means that this is quite a strong study, as Mr. Hashim said at first. Next slide, please, Mohammed. As I said, 1-to-1 randomization between the patients. 264 of them were assigned to have a uni knee, and 264 were assigned to have a total knee. So 50% and 50%. In each group, it had 153 males and 111 females. And even the left and right knees numbers were similar, numbers 140, 124. So I mean, 20 difference is not a big difference. And then the Oxford knee scores varied from 18 to 8, meaning that these patients definitely needed a surgical intervention at some point. And for the total knee, the patients who were assigned to have a total knee, their Oxford knee scores was between 0 and 19. So even the arthritis severity was even worse for these patients who needed a total knee. Operation timing, so meaning the timing in theaters as a surgical time, was similar between both groups, roughly about 70 minutes, just over an hour. And then the other main point that was looked at is the length of the stay in the hospital post-operatively. That included the day of the surgery. So the uni knee, they roughly needed about 3 days. For the total knee, they needed 1 more day, about 4 days and a half. Next slide, please, Mohammed. As I mentioned earlier, the study, the findings they looked at, the uni knee was found to be more cost-effective and less expensive as compared to a total knee, which kind of makes sense. Obviously, you're replacing half of the knee rather than replacing the whole knee itself, which can include the patella as well, which adds to the cost and surgical time. The other finding was slightly better outcomes for patients who had a uni knee rather than a total knee. And that the outcomes were measured with the Oxford score, as mentioned earlier, and the American Knee Society, and also patient satisfaction. They expressed that they felt better and earlier recovery and earlier return to work and day-to-day activities following the uni knee. Next slide, please. So a discussion. So the paper included a discussion. This largest randomized controlled trial comparing between the total knee and the uni knee, and is actually the strongest evidence that has been published so far between these two implants, with the biggest sample size, about 500 patients, or sorry, even more than 500 patients, and the longest follow-up, about 5 years, which is quite actually a long time to follow up. Usually in day-to-day clinics in here, we follow up the patients average about 6 months, and then they're discharged afterwards. So to carry on follow-up 5 years, it actually makes the study worthwhile and significant, rather than just a short-term study for a year or so, which patients can later on deteriorate, or like their satisfaction can decrease by time. And again, most importantly, it's unbiased, so it wasn't funded by a certain company, it wasn't funded by a certain group, which may have influenced the results towards this implant or that implant, or towards a total knee versus a uni knee, or a certain knee implant. Next slide, please. To carry on with the discussion, despite how strong this paper is and how robust this evidence, it still had some problems. The main problem was the masking, which in simple terms, the surgeons knew which patients will probably do better and which patients will probably do worse. And they knew that this patient I've signed up, because I've seen the patient in the clinic, I will sign him up for a total knee, which kind of makes me a little bit biased towards the outcome for the uni knee will be better, or a total knee will be better, because I've selected this patient, and I know, and I'm deep down inside my mind, I think that this patient will do better with that implant. So there's a little bit of what we call selection bias, or personal bias, regarding this paper by the surgeons. The other thing was that it wasn't very easy to kind of mask the patients, or separate them throughout the period of the 5 years. Eventually, patients meet up in the clinic waiting to see the surgeon, or after, or during the surgery, or after the surgery, sorry, in the hospital, and they see each other in the rooms or the ward. And obviously, having done similar surgeries, they talk about the surgery. So one patient said, "Oh, I've had a uni knee." Another patient said, "I've had a total knee." And then patients see each other. So a patient who's had a total knee remained in the hospital for a day longer. And he might have thought, well, this patient who had a uni knee actually came, stood up earlier, walked up earlier with the physio, and he wasn't in too much pain, not like me, and he actually left the hospital earlier. So it might have been influenced that some patients who had a total knee might have felt, well, my pain is a bit worse than a patient who had a uni knee, and I might have been better off if I had a uni knee. But that was kind of expected, to be honest. But still, it might have influenced the results a little bit. Also, there was some missing data. Some patients declined follow-up at some point, or didn't turn up, or were lost for any other reason, as well as non-compliance. The other option, despite it's 5 years, big, robust study, long-term follow-up, but you always would need a longer-term follow-up. It would have been better if it was 10 years, 15 years, but obviously that means more cost, more burden on the clinics, and more burden on the research and the funding. And finally, patients' expectations and outcome differ after 5 years. So you might meet a patient after a year in the clinic, would tell you, yes, glad I've had my knee, very happy, it's doing excellent. See him later, 2 or 3 years later, this knee is not as good as I thought it was going to be. I'm having this problem, having that trouble. My knee starting to hurt again. I wish I had a total knee at first. I wish I didn't have the total knee. I should have had a uni knee. I might have been better off. So that might have another influence. Next slide, please. Mr. Hashim, can you please put the next slide? So the interpretation outcome, as final words regarding that study, both are effective. Both offer pain relief for the patient. Both offer similar outcomes and similar incidence of reoperations and revisions based on the outcomes of or the findings of the study. But the main thing, or the main outcome that we came up with, or that was came up with the study, is that a uni knee is better cost effective and is cheaper to do in the NHS as compared to a total knee. And patients who had an isolated, and I have to stress this, an isolated medial compartment arthritis would be better off to have a uni knee rather than a total knee. And this was my final slide. Thank you very much. I'd like to take any questions if anyone has. Yes, please. Yes, please. Yeah, I can hear you, sir. Yes. Yeah. Yes. Agreed. 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 Yeah, agreed. And actually, Dr. Muhammad, I've actually seen surgeons here who might think, well, who actually did uni knees on patients who had ACL insufficiency or rupture, but their knees were stable and they had good muscles otherwise. So they actually, so even that contraindication can be changed from one surgeon to another. But I agree with you. It's always better to have a total knee on standby if you're doing a uni knee. Personally, I think the contraindication, the main significant contraindication, if I mean, it doesn't really happen in Egypt, but I think it happens in the NHS here. Patients are listed for the surgery in the clinic, and then by the time waiting in the waiting list, and by the time they come to the surgery, they might have seen in the clinic with X-rays, and it shows only medial knee arthritis. But they wait 6 months, they wait a year until their turn comes to the surgery, and then when the surgeon opens up, it's like full tibiofemoral arthritis or even PFJ arthritis as well. And at this point, surgeons might change their the surgery to a total knee. But I agree with you, Dr. Muhammad. The main contraindication is the tricompartmental arthritis. Otherwise, you can do whatever you like as long as you're comfortable with it, and as long as you think that this patient will benefit from that, whether it's a total knee or a uni knee. I prefer fixed bearing. I prefer fixed bearing. I think again it varies on the surgeons, but I've seen a couple of times mobile bearing, and actually a lot of surgeons that I see now, they kind of trending is to use the fixed bearing knee rather than a mobile bearing knee.
Yes, sir. Have you been faced with the dislocation of the insert, sir?
Yeah, I have. I have a couple of times. In intraoperative, I was doing a lateral uni knee, and the bearing, the trial, not the actual bearing, the trial fell posteriorly behind the knee, and it was a very tricky situation, quite stressful. It took me about like half an hour to pick it up again. It was really difficult. That was during the surgery, but luckily this patient carried on well, and it didn't dislocate afterwards. But later on, I've seen patients in the clinic. No, sorry, in the clinic in A&E after a knee trauma or injury with a dislocated bearing.
Yeah,
it happened. Yeah, it did happen.
What do you think
So
the reason for?
Just a quick. I'll come in for this, Professor Ashhab. So there is another novel paper coming from Oxford about the unnecessary contraindication for unicompartmental. I don't think there is a clear an absolute indication to change your mind intraoperative, except if the MCL has gone. If the MCL hasn't gone, so every case with medial compartment arthritis can have a uni knee. And with the fixed bearing, the point is you avoid all the minimal instability. So ACL deficient, BCL deficient, all this. If there's no gross instability, you don't have any indication to change from uni to total. except if for unforeseen reason the MCL has done. And this is the time you need not only a total knee, but even a constrained total knee. Other than this, uni knee can work for everyone. The trial, the TopCat trial come with just to confirm what we're having in our daily practice. So really, uni knee is a very valid option. Patient comes out from you with uni knee very happy. The PROMs, our patient reported outcomes, are much better in uni knee. Uni knee has a very better rehab. Patient is out from hospital very soon, more than total knee. They came out from the two to 3 weeks of pain and swelling with the total knee. With the uni knee, they are moving day one full range, because you basically maintain the mechanics of the knee. You haven't touched the ligaments, so the soft tissue balance and the mechanics of the knee are still working with the uni knee. So uni knee is a magic option, and all the problems happen with Oxford or the mobile bearing before has been now avoided with the fixed bearing. And many companies now is changing to fixed bearing, including Debui Senses. They are going now to having now a fixed bearing. Persona or Zoc, they have now a fixed bearing. Lima has a fixed bearing. So I think fixed bearing uni knee is a very valid replacement for a total knee if we're speaking about an isolated medial compartment arthritis.
Yes, you're absolutely right.
We can discuss the papers about the unicompartmental specifically in another journal club. So as we agree, the journal club can be about a specific topic, and we get different papers covering this specific topic. Today we concentrated on a study design. So the study design was a randomized control trial. So both of them are randomized control trial. And we can, for the next journal club, we can concentrate on one topic, like a unicompartmental knee, get all the relevant novel papers speaking about unicompartmental knee, and I think will be very useful. It's a hot topic. All the people now, knee replacement is growing and growing and growing, and people are getting elder and getting active more than before. So the knee replacement is getting more and more widely done. So I think what type of knee you are using is very important.
Yes.
The only concern about this trial is it hasn't involved the type of the knee or the brand of the knee. So what total knee did they use? What unicompartmental did they use? The second thing is the main accusation for the unicompartmental knee is progression of arthritis. So longer follow-up is needed. So, and I think they will do another a TopCat 2, which will be looking into 10 years follow-up, and we are waiting to see the results of this one, because 5 years doesn't address this problem, which is progression of arthritis and need for another operation with replacing the uni knee with a total. But otherwise, the TopCat trial supports the evidence we see in our daily practice, and a really good paper and a good trial to use in your practice. Any questions from the floor?
I think you are absolutely right, Dr. Hashim, because the last guidelines and the recommendations from Keble College, Oxford, I attended in the course of unicondylar knee replacement. All the contraindications are now declining, and now I think the only absolute contraindication is MCL.
Yeah, totally agree with you, Dr. Muhammad. Totally agree. The only absolute one is tricompartmental and medial MCL insufficiency.
Yes, I have just one last question, Dr. Muhammad, because I have a paper on unicondylar knee replacement. You think the dislocation of the insert is mainly because the surgeon didn't remove the osteophytes properly?
It's hard to tell. To be honest with you, it's hard to tell. I don't think that's the only reason. It might be one of the reasons, but I don't think that's the only one. I find I've seen a patient who.
Professor Ashraf, you hear me?
Yes, sir.
Yes, I can hear you.
I think because we are on time, so that's why it should be stopped. Okay. So good. Thank you so much, everyone, for attending.
Thank you so much.
Really good time. I appreciate if every one of you do the feedback form. You will receive the feedback form with email, and you will receive your certificate once you're done with the feedback. Thank you so much, everyone.
Thank you so much. Thank you, Dr. Muhammad.
Pleasure.